Dear students, in the continuity of the chapter of the hypertension, today we are going to discuss about the pheochromocytoma. When we talk about the pheochromocytoma, first of all, we should know what is pheochromocytoma. Pheochromocytoma is basically the neuroendocrine tumor. Pheochromocytoma is the neuroendocrine tumor which is derived from the chromaffin cells of the adrenal medulla. As we know well, when we talk about the adrenal gland is divided into two parts. One is cortex and one is medulla. When we talk about the cortex is divided into three parts: the zona glomerulus, zona fasciculata, and the zona reticularis. Adrenal medulla basically are responsible for the secretion of the catecholamines. What are the catecholamines? Catecholamines are epinephrine, norepinephrine, and or dopamine. So these are released from the adrenal medulla. So what happens when there is a tumor? The increased amount of this kind of chemicals, which we call the catecholamines, are released. So pheochromocytoma is the neuroendocrine tumor which is derived from the chromaffin cells of the adrenal medulla. Beside this pheochromocytoma may also arise from the paravertebral sympathetic ganglia. Paravertebral sympathetic ganglia. That's why we call it extra-adrenal pheochromocytoma. This is called the extra-adrenal pheochromocytoma. This is a rare tumor basically, but extra-adrenal pheochromocytoma can also occur. And pheochromocytoma basically is the neuroendocrine tumor of the adrenal medulla. So we are discussing the pheochromocytoma. Now, how the patients present with the pheochromocytoma? When we talk about this disease, the patients usually present with the classical symptoms. And what are these classical symptoms? Number one is the paroxysm of the hypertension. Paroxysm of the hypertension means the hypertension are not usually in a continuous way. There are the paroxysm of the episodes of the hypertension which occur, and beside this there may be the palpitation, there may be the diaphoresis, and there may be the headache. These are the classical presentation. These are the classical presentation of the pheochromocytoma. But it is not necessary that beside paroxysmal hypertension there are other features like diaphoresis, like headache, like palpitation. But the paroxysmal hypertension is the common feature of the pheochromocytoma. Now the patient basically there are no risk factors for the pheochromocytoma, but certain kind of diseases may be associated with this disease. So pheochromocytoma may be associated with the multiple endocrine neoplasia type 2 and 2b. So it is maybe associated with the multiple endocrine neoplasia type 2 and 2b, may be associated with the neurofibromatosis, and may be associated with the von Hippel-Lindau syndrome. So von Hippel-Lindau syndrome, neurofibromatosis, and multiple endocrine neoplasia 2A 2B may be associated with the pheochromocytoma. Basically, this pheochromocytoma is also called the 10% tumor. Why we call it 10% tumor? We call it 10% tumor because it can be there may be the chances of 10% if the tumor may be bilateral. There are 10% chances then the tumor may be in the pediatric group. There are the 10% chances that it may be the extra-adrenal, and there are 10% chances that tumor may be the familial. So we can say, and this is the 10% tumor that we call. So this is the pheochromocytoma which we discussing, and we are discussing how the patient present with the pheochromocytoma. Pheochromocytoma patients may present with the classical symptoms which we discussed before, and we have discussed the risk factor associated with the pheochromocytoma. Now, how do we test? What test we do to diagnose the pheochromocytoma? If we want to diagnose the pheochromocytoma, we are supposed to do the certain kind of test. If we are in doubt that it may be the pheochromocytoma, then we are supposed to send the serum metanephrine levels. We are supposed to check the metanephrine in the free metanephrine in the blood, and we are supposed to check if the metanephrine levels are high, then we are supposed to check the unfractionated metanephrine levels in 24 hours of the urine. So first of all, we are supposed to check the metanephrine in the blood, and if the metanephrines are high, then we are supposed to check the 24-hour urine unfractionated metanephrines. If these are also suggestive of pheochromocytoma, then we are supposed to proceed for the other test, and these are tested the MRI or CT scan. So when we found the high metanephrine levels, we are supposed to do the MRI or CT scan. But if MRI or CT scan are not able to find out the pheochromocytoma, and the clinical features or clinical presentation is associated, and clinical presentation is like that of pheochromocytoma, then we are supposed to confirm the tumor. So for confirmation, we are supposed to do the MIBG scan. Besides this, we can do the 18F-FDG PET scan to diagnose the tumor and to diagnose the metastasis of the tumor. tumor. So these are the basically investigations which are we supposed to do in the case of pheochromocytoma. So after diagnosis of the pheochromocytoma, we are supposed to do the treatment. How do we treat? The only treatment of the pheochromocytoma is the resection, surgical resection or surgical removal of the tumor. But to remove the tumor, we are not supposed to diagnose the tumor by doing the biopsy. Before removal, we are not supposed to do the biopsy, because if we do the biopsy, the increased amount of the catecholamines will release, and increased amount of the catecholamines will lead to hypertensive crisis, and there may be also the death of the patient. So we are not supposed to do the biopsy. So after diagnosing the pheochromocytoma, we are supposed to remove the tumor, and before removal of the tumor, we are supposed to give certain kind of medicines. What are these certain kind of medicines? First of all, we are supposed to block the alpha blockers. We are supposed to block the alpha receptors. How do we block the alpha receptors? We can block the alpha receptors. Basically, we block the alpha receptor 14 days before the surgery. 14 days before the surgery. So we can give the non-specific alpha blocker, when we can give the specific or selective alpha-1 alpha blocker. So if we talk about the non-specific alpha blocker, we can give the phenoxybenjamin. Phenoxybenjamin is usually given in the dose of 10 to 20 milligram once a day, 14 days before of the surgery. And if we talk about the selective alpha-1 blocker, we can give the prazosin, we can give terazosin, or we can give doxazosin. So we are supposed to give the alpha-1 blocker 15 days before of the surgery. Once we have done we have blocked the alpha blockers, we are supposed to give the beta blockers. Why do we give the beta blockers? Beta blockers we usually give to subside the symptoms and to control of the blood pressure, like palpitation and to high blood pressure. We can give the beta blockers. But before alpha blockade, we are not supposed to give the beta blocker. If we give the beta blocker before the blocking of the alpha blocker, there may be the hypertensive crisis. It will be difficult to control the blood pressure. Another choice or another option is the calcium channel blocker. We can also give the calcium channel blocker to control the blood pressure during surgery, or we can give the IV calcium channel blocker during the surgery. So this is the medical management during the surgery or before the surgery. And we can also give the metyrosine for the control of the catecholamines, to decrease the amount of the catecholamines during the surgery. This is also an option. So metyrosine can be given before the during the surgery to reduce the increased amount of the catecholamines. So in the series of the chapter of the hypertension, we have completed the pheochromocytoma. Thank you.